Good evening, all. I am Venkat Pawan Kumar. I am presenting our study, comparative study of 2D speckle strain and stress analysis of left ventricular function among children before and after closure of moderate and large ventricular septal defects. Although the ventricular septal defects is the most common congenital heart disease, still some knowledge deficits exist, just as in any part of science. We know that morphology, embryology, hemodynamic, natural history, and treatment of ventricular septal defect has been fairly established. However, there is still some unknown knowledge deficits regarding ventricular septal defects, such as why different children behave differently. Some develop heart failure and some do not. So different VSTs behave differently. Some decrease in size and close and some do not. We did our study to know the part of unknown. Aim of our study is to know various echocardiographic parameters of left ventricular systolic and diastolic function among children with VSD and study how these parameters change after the VSD closure. We included in our study the children with hemodynamically significant ventricular septal defects undergoing either surgical closure or transcatheter closure. However, even among these children, those who are started on inotropes before the inclusion in the study are those children who developed complete heart block, and the children with small VSTs are excluded from the study. All the children planned for the VST closure are evaluated day before the intervention. The information related to the symptoms, clinical examination, anthropometry, clinical cardiac examination is obtained. 2D echocardiography, Doppler studies, M mode, strain analysis are done to measure various parameters of left ventricular function. Repeated evaluation after the VST closure is done at 1 to 6 weeks after the closure of the VST. Statistical analysis of these parameters is done using SPSS version 22. As you can see here, we compare different parameters such as global longitudinal strain, myocardial performance index, end systolic LV stress, fractional shortening, velocity of circumferential shortening, and early diastolic tissue Doppler and diastolic filling patterns. And we compared these parameters before procedure among device and surgical groups. As you can see here, the p-values did not differ significantly among device and surgical groups, both in the systolic parameters and the diastolic parameters. Surprisingly, there is a pattern which we noted, the diastolic filling, which is in uh, monophasic in eight children in surgical group and none in device group. This is the monophasic filling diastolic pattern, which converted into biphasic diastolic pattern after the surgical closure. And we compared these parameters post-procedure in GLS, myocardial performance index, end systolic LV stress. All these parameters post-procedure we compared device and surgical group. And again, similarly, there is no significant difference either in the device group or in the surgical group. There is no statistically significant difference after the VST closure. Then we again compared the same parameters within the device group before and after, and again in the same group there is no much statistically significant difference or significant reduction or increase in these values in both systolic function and also in the diastolic function. Similarly, in the surgical group, the same pattern repeated, except for E dash, which changed significantly, which actually decreased after surgical group. That it indicates that decreased filling after the surgical closure of the VST. This is a bullseye plot showing the global longitudinal strain of -15 in a child before VST closure. Conclusions in our study are: left ventricular global longitudinal strain in children with VST is in normal range, and GLS did not change significantly after VST closure. GLS did not differ significantly between surgical and also device groups. Similarly, end diastolic left ventricular stress, velocity of circumferential shortening, myocardial performance index are in normal range in children with VST, and all these three parameters did not change significantly after VST closure. Monophasic diastolic filling pattern is seen in surgical patients before VST closure, which disappeared after VST closure. This pattern of diastolic filling is not seen in device group. This is the only significant finding which what we found in our study group. Limitations of our study are left ventricular twisting and shortening of the individual myocytes underlie the left ventricular systolic function. In our study, we assessed longitudinal strain alone. Other forms of strains are not assessed. Mean age of the study subjects was significantly different among both device and surgical groups. Sample size in our study was small, and this may have resulted in acceptance of the null hypothesis. Thank you.